Hello, so this is chapter 32, the process of treatment. The decision to seek treatment. The most important factor in recovery appears to be readiness to change. An actual admission to treatment is accumulation of the decision to end or reduce one's alcohol or drug use. Assessment should identify substance misuse level as well as severity of the consequences of the SUD. Those seeking treatment tend to be more impaired and have more severe life problems. On average, people with SUDs seek professional treatment after about 5 to 8 years of dependence on a chemical, or 10 to 19 years of heavy abuse. Methods of treatment 1 of 2. Motivational interviewing. Core elements include collaboration, empathy, identifying discrepancies between the goals/values and behaviors, recognizing autonomy, and support during change. Cognitive behavioral therapy, CBT. Individual has developed a series of false or irrational assumptions that underlie his or her SUD. These core assumptions are expressed through the individual's thoughts or self-talk. These are usually carried out either through a series of individual or group therapy sessions. Voucher-based reinforcement involves the distribution of vouchers worth a certain number of points to even credit at a local store for periods of abstinence confirmed through urine toxicology testing. If the individual fails to earn sufficient points to be able to obtain the desired item, staff help the individual identify the obstacles that are preventing him or her from achieving that goal. So the stages of recovery 1 of 6. So stage pre-contemplation behavior. Individual is still actively using chemicals and has not thought to stop the use of recreational chemicals. Individual might not see use of chemicals as a problem. Therapeutic challenge. Teach client about effects of drugs, of abuse, and risk associated with their use. Help client build self-esteem. Help client identify barriers to recovery. Relapse pathway. So they all seem to say relapse pathway on it. So anyway, so the next stage, contemplation. Individual is still actively using chemicals but has ambivalence about whether she or he wants to continue. Teach client about effects of drugs, of abuse, and risk associated with their use. Enhance motivation for change. Relapse pathway. Stage number 3, preparation and determination. Individual has decided to quit in the immediate future. Enhance motivation for change. Help individual make behavioral plans to support impending change. Stage 4, action. Individual has started to try to avoid further chemical use. Identify relapse triggers. Help individual recognize symptoms of impeding relapse. And then you have the maintenance stage, which individual has made behavior change to and continues to work and learn behaviors that will support recovery from chemical use. Enhance stability of change. Help individual identify and deal with any personal issues that might be a threat to his or her recovery program. And then there's the termination stage. Patient has made cognitive changes that support abstinence. So these next few slides, when this is 3 of 6, it goes over each stage in detail. So pre-contemplation. Individual still actively abusing chemicals and has no thought of trying to abstain or discontinue. Defense mechanisms such as denial and rationalization are most prominent. Contemplation. Individual begins to entertain vague thoughts of stopping one of these days, typically within 6 months. Preparation. Client is ready to change attitudes and behaviors. Assist client in making realistic decisions and goals. Action. Client takes concrete steps to modify the identified problem behaviors. Maintenance. Abstaining for 6 months. Focus on behaviors to maintain and support recovery. Termination after 5 years of abstinence. Nowinski's 2003 stage model of recovery. Acceptance. Benefits no longer outweigh consequences of substance use. Surrender, willingness to make lifestyle changes develops. Reactions to stage models of recovery. Such models are descriptive rather than explanatory. Progress through stage is very individual rather than predictable. Then what works in predicting recovery from SUDs? The foundation on which a client's recovery might be established appears to include interpersonal relationships, cognitive reappraisals, demographic variables, severity of the SUD, involvement in AA or religious groups, individual expectations, and self-evaluation. Should abstinence be the goal of treatment? Specific points to address in substance rehabilitation. Range of issues that must be resolved. Should total abstinence be the appropriate goal? What factor would interfere with abstinence? What is the motivation and what level of care is needed? Alcohol. Identify consequences of their AUD. Its impact on them and their families and friends. Determine if abstinence is a worthy goal. What are motivating factors and barriers to recovery? Narcotic analgesics, very dangerous. Many die of this addiction. Chronic relapsing pattern, CNS stimulants, traditionally not a reason for admission to an inpatient detox facility, unless there are other medical complications. May also be admitted of other substances being misused in a dangerous combined manner. Marijuana abuse. Only about 10% of those who abuse become addicted. Anabolic steroids, different motivations, enhanced physical appearance, desire to build muscle strength. Complications may not appear until years after abuse, and then there's hallucinogen abuse. So that's it for this chapter. Thank you for listening.